I'm Julie Shaw. I'm the Home Care Package Coordinator here in the Riverland. Home Care Package consumers are quite complex consumers. Their funding ranges from, an hour a week through to, 12, 14 hours a week. So very complex situations in the home. Therefore, we have a lot of hospital admissions over small situations which really could be managed if they had some clinical help within the home. Our project was called Consumer-Led In-Home Monitoring. We introduced the virtual clinical care team into our consumers' homes, assisting them with their health knowledge and keeping them out of hospital, which was the aim.
My name's Laura Hoffman and I'm one of the chronic condition nurses that work in the virtual clinical care hub. So we were brought in to link up with Home Care Package team to identify and monitor clients in the community who have complex needs to try and keep them out of hospital. So we introduced our equipment, telemonitoring equipment, into the client's home with education and helped them to monitor themselves daily and upload their results and give them feedback on their symptoms. We designed Mr. Feltman and Wolf, his dog, to demonstrate just how many people and services can be involved in helping a client to get their best possible care at home. So we found over the 6 months that the project ran and the 8 clients that we had on board that we actually potentially avoided 22 hospital admissions and 31 ED presentations just by early intervention and helping the client recognise when to seek medical review.
Some of the outcomes we saw was support staff that went out actually commented that their health knowledge and knowledge of the consumer's conditions had greatly improved.
So my name's Anita Urbano and I'm the Director of Pharmacy for the Central Adelaide Local Health Network. We know that medications are the most common intervention in healthcare and they bring lots of benefits to people, but they can also be a cause of patient harm. About 20 to 30% of hospital admissions for older people may be related to medication-related issues. What we wanted to do was identify the risk factors for those patients to have a re-presentation to hospital due to medication risk or medication misadventure.
My name is Sally Marotti. I'm the lead pharmacist for research for SA Pharmacy. The project we focused on was looking at identifying our high-risk patients. We collaborated with the University of WA to utilise an algorithm that they'd created to identify patients that are high risk of readmission or having adverse events after being discharged from hospital.
My name's Kate Jenner and I'm a clinical team leader pharmacist for our acute and urgent care team. We had the opportunity to collect data over a 4-week period. During this 4-week period, we had 49 patients discharged from our acute geriatrics team. We focused on the patients that were discharging home, and out of that 49, 24 were discharged home. From there, we used an algorithm to determine 6 of those patients were high risk, and we then sent a home medicines review referral to the GP.
I'm Hannah Batenko. I'm one of the speech pathologists that works with the Silent Home Rehab team. The project that our team identified was the issue surrounding the percentage of patients on our program that were readmitting to hospital. Between 8 and 18% of all of our patients were actually returning. Readmitting to hospital, we found, was stressful for patients, causing likely increased length of stay and further deterioration and deconditioning for them and putting them at greater risk of hospital-related infections. And it was also quite stressful on the service and on staff in terms of interrupting length of stay. And overall, we wanted to really see if there were some factors that we might be able to identify to reduce those readmission processes.
My name's Angela Gantley and I'm one of the rehab coordinators that works within rehab, and we triage for home rehab. We looked at home rehab pharmacy, getting a clear discharge medication list from the acute ward pharmacist prior to coming into home rehab. Looked at our discharge summaries, verbally requesting and documenting the importance of a discharge summary from acute prior to accepting into home rehab. If it was a complex patient, we requested home rehab medical team review the patient on the ward prior to discharging. We also looked at improving the communication loop when a patient was transferred back into ED from our home rehab program back into the acute ward.
I'm Kate Viles. I'm a nurse consultant in palliative care in a liaison role at Flinders Medical Centre. We identified that end-of-life care planning for patients transitioning from hospital to residential aged care for the first time was not always managed in a consistent and timely manner. We found that there was ambiguous language on their 7-step pathways, and goals of care had not always been broached with the patients.
My name's Julie Stafford. I work in care awaiting placement at Flinders Medical Centre. And we decided to do some auditing around 7-step pathways and advanced care directives. We used a focus group from care awaiting placement, and we discovered that around 43% had varying degrees of documentation on their 7-step pathway. 18% had no written goals of care on their 7-step pathway.
So we sent out some pre-education surveys to test the trainee medical officers' knowledge and confidence levels at completing 7-step pathways and having those goals of care conversations.
I'm Dr. Ruchi Saxena, and I'm a consultant geriatrician with Salin, and I was involved as a medical champion with the STAR SA End of Life Care project. The most important part was a mutual learning with the training medical officers about what they expect from their seniors and how to identify the end of life care.
My name's Sue Nidek, and I'm the nurse consultant for geriatrics for Narlan District, and I'm based in Mulberry Hospital. This project actually started as part of the COVID outbreak. It was identified that 40 to 60% of our presentations to ED are older people from nursing homes, and the impact that a COVID outbreak would have on that. So basically how we could actually do some in-reach care for these people in their facilities and stop them coming into hospital.
My name is Amanda. I'm a nurse consultant working in the geriatric service within the Division of Rehabilitation and Aged Care here at the REPAT. Elderly patients who present to hospital are at increased risk of iatrogenic complications. A lot of these presentations could be avoided should there be an alternative pathway. We wanted to see whether creating a pathway between the residential aged care facility and or the GP via SAS to the geriatrician could improve the access to geriatric services and in turn reduce the amount of avoidable admissions to hospital.
And my name's Helen Burville. I'm a geriatric nurse consultant from the Royal Adelaide Hospital. Across all 3 local health networks, we were able to have between 72 to 76% of referrals from residential aged care facilities remain in the facility and have input from our service.
I am a senior clinical social worker here at the Royal Adelaide Hospital, working in EDGE and geriatrics. So EDGE is over 80s presenting to the emergency department. These people are at a higher risk of readmission or representation to the hospital. So it was actually identifying that there is a gap here. So we're sending these patients home with what happens next.
I'm Lainey Rawlins. I'm a clinical nurse working on the Something Missing in the Middle care transition service for over 75s. Researchers at Flinders University got together and with older people and came up with a project that there was something missing in the middle between leaving hospital and transitioning back into the community. That's the primary focus, is the older person's goals.
My name's Matt Jeffs, and I'm the allied health assistant or welfare worker for the Something Missing in the Middle project. We've referred them for ACATs, increase their supports if they're already on an ACAT, and education to clients about the services, and provide the support and assistance to family. And we can provide transport from hospital to home. We've taken them to GP appointments and outpatient appointments, shopping, to the pharmacy. We can provide short-term assistance with domestic tasks as well, such as cleaning the floor. I've done a bit of gardening, and also advocate for clients.
So my name is Dr. Chad Collins. I'm a general practitioner and the Northern Adelaide Local Health Network GP Liaison Officer. So the problem that we identified was around geriatric patients with behavioural issues having delayed placements into residential aged care facilities. And that's a barrier obviously to then going to a residential aged care facility because they weren't accepting those patients with those behavioural challenges. As part of that work with our group, we did some data analysis, and we found that those patients had significant lengths of stays in hospital prior to placement.
So I'm Sue Nidek, and I'm the nurse consultant for geriatrics here within Narlan. What we decided to test was if we could influence and support a facility in transitioning these people from the GEM unit into that facility and then allowing them to stay there without representing to hospital.
I'm Xiang Lo, consultant geriatrician with the NALHN, currently with the Geriatrics in the Home program. So the outcomes of this GEM to RACF project was that we've managed to facilitate earlier discharges for some of our patients into facilities, and our nurse consultant, Sue, has been able to provide education and support for the facility and the staff there to empower them and to educate them to allow the patients to transition successfully into the permanent placement.